St. Raymond's Pediatric Hospital did not close it. Changed ownership. Most institutions that fail are remembered through headlines and lawsuits. St. Raymond's was not that kind of institution. It ended quietly, through restructuring, asset transfers, and rebranding when it disappeared from public maps in the late 1990s. Most residents assumed it had simply moved. They did not ask where the children went. They did not ask where the staff went. They did not ask what happened to Ward C. To understand the program, we must begin with the hospital itself. St. Raymond's opened in 1958 as a regional pediatric facility. It served Providence and the surrounding areas of Rhode Island, drawing patients from lower income neighborhoods and rural communities. Most families used it as a safety net. Few could afford private pediatric care in Boston. During its first decades, the hospital focused on common childhood illnesses, respiratory infections, congenital disorders, burns, and injuries. This changed in the mid-1970s, when cases of behavioral disorders increased nationwide. Schools and courts struggled to manage children who did not respond to standard discipline or medication. Parents, overwhelmed and without alternatives, sought referrals to psychiatric facilities. St. Raymond's adapted it, expanded its pediatric psychiatric unit. The unit occupied a narrow wing behind the main hospital. Officially, it was part of the pediatric program. Unofficially, it operated with its own staff, its own budget, and its own clinical philosophy. The wing was known as the Neuropsychiatric Behavioral Unit. Internally, staff called it Ward C. Ward C did not treat all children. It treated a specific subset, those who did not respond to conventional behavioral interventions. Admission criteria included nonverbal behavior, aggression, sensory dysregulation, and persistent defiance. Many children were referred by family courts. Some came from schools. A few were surrendered by parents. Directly. Ward C did not view these children as patients. They were participants. The behavioral philosophy of the time emphasized compliance, not comfort. Doctors believed the primary barrier to rehabilitation was resistance. If resistance could be eliminated, function could be taught. If function could be taught, independence could be achieved. This belief shaped everything that followed. By 1979, Ward C had developed its own internal classification system. Children were assigned to categories based on responsiveness and compliance. Documentation from the period shows categories such as passive nonverbal, active nonverbal, verbal, defiant, sensory, regressive, aggression. These classifications predated standardized psychological diagnostic tools. They were functional, not clinical. They allowed staff to predict which children could be conditioned to follow orders and which could not. In 1981, the hospital received its first major foundation grant. The grant was not advertised publicly. It was issued by a private foundation based in Boston. The stated purpose was to study methods of behavioral compliance in nonverbal pediatric subjects. The hospital accepted. There were no hearings, no public oversight. No media announcements. Behavioral research was legal. Private grants were common. Few questioned the ethics of compliance-based programs at the time. Children in Ward C remained in the hospital full-time. They slept in shared rooms. They ate separately from other pediatric patients. They did not attend school. Education was not considered a priority. Compliance was. In 1983, the foundation renewed the grant. This time, funding expanded. Ward C hired new staff, purchased new equipment, and reallocated resources from other departments. Hospital administrators cooperated. Funding was funding. Few hospitals refused money in the 1980s. By 1985, Ward C had begun Phase 2. Phase 2 expanded the concept of compliance beyond observation. It introduced environmental conditioning. Children were placed in controlled settings designed to reduce sensory input and eliminate behavioral resistance. These environments were quiet, consistent, and repetitive. Schedules were strict. Movement was limited. Silence was preferred.